Welcome, everyone, to episode number 22 of the Eternal Vitality Podcast. I'm your host, Dr. Jesse Morse. I am a double board certified physician in both family medicine as well as sports medicine, and I spend most of my day analyzing several different body parts, one of which is the shoulder. We're going to talk about shoulder injuries today, but in particular, dislocations and labral tears. Unfortunately, these are very common, and the tricky part is, do they all require surgery? Are there different levels of these? So we will break these down. This is going to be a combination of informative for regular people, but also super informative for physicians and other medical professionals that may be treating these. Now, in general, most people present with a shoulder injury with pain, what we call instability. You can have grinding, locking, or even catching. Certain maneuvers, that hurts, and they have to move their shoulder out of that position and into a different way. Some people even feel it slipping out of place. Now, most people feel the pain in the front of their shoulder. That is by far the most common. You can have pain in the back, but that's much less likely. Think seizures, think electrocution. That's traditionally where we have our posterior issues. Now, often these are combined with an injury to the biceps tendon, with either the subscapularis or the supraspinatus, which are two of the most important rotator cuff tendons. Now, pain can often be reproduced using certain maneuvers, certain motions, and even when you lift something up, or if you are doing it in a very specific manner where maybe your thumb is down or to the side, or if you're falling, you try to break your fall. That's classically how these happen. Or you can have direct trauma. Think of, you running into a door frame, getting run into as if you're a football player, and the shoulder pops out of the socket. Now, the position of the arm is very important in this. Certain times you may be lucky, and other times it may be awkward. And if you fall an outstretched hand like this, it may be completely different than if you fall like this. So the angle of the arm sometimes is awkward, and that usually translates to worse injuries. Now, you can have this can be caused by overuse, or this could be caused by acute trauma or dislocation. You can have a partial or complete tear, and I'll discuss each of those in a minute. Sometimes acute dislocations require a trip to the emergency room, where anesthesia is required to knock the patient out to put that shoulder back into place. A lot of the times they what we call self-reduce, and they can kind of maneuver it back and it will pop back into the place. Obviously, the longer it's popped out, the more severe it's popped out, the more accompanying damage is going to come along with it. Let's talk now about the anatomy of the shoulder. Now, the anatomy of the shoulder is similar to the hip, but the shoulder has way more range of motion and way more crazy angles. Think about all the different angles that we can do with our arm that you can't do with pretty much any other body part. The elbow has a lot of range of motion, but it can't deal nowhere near as much as the shoulder. So that's part of the reason this happens so often, is because of how many ways it can move, and how many different structures are responsible for stability when it moves. And we'll talk about that in a sec. But what you basically have a proximal humerus or arm bone that attaches, or that doesn't really attach, it sits on top in the middle of a glenoid, which is the cup part of the ball and cup. And think of the glenoid as almost like a paper plate, and the actual ball or proximal humerus as like a beach ball, and it's kind of sitting in the middle there. And if something shifts or something, then that ball doesn't sit right, and then things, one is stronger than the other, and you start to lead to different issues. Now, there is a thick capsule surrounding that ball and socket that helps to protect the joint. And it's a thick fibrous tissue. Within that is the labrum. Now, the labrum is a thick piece of, I call cartilage just because it's easy to describe, but it actually contributes to about 50% of the depth of that labrum and that ball in the socket. So if you don't have the labrum, the ball's not gonna stay in the socket. So you really need the labrum because it makes up half of that, that suction to kind of stay in there. Now, there are three main ligaments that are responsible for movement in the shoulder and that can get injured. The anterior internal glenohumeral ligament, or AIGHL, is the most important one and is the main restraint. We're thinking about 90 degrees of abduction and external rotation. Now, the middle glenohumeral ligament does about 45 degrees of abduction, and it does external rotation, as well as the SGHL does basically static movement when the arm is directly to the side. Now, think of the labrum as a clock, where you have the top as noon, 3 o'clock would be the front, 6 o'clock would be the bottom, and 9 o'clock would be the posterior. Similar to the hip, the shoulder clock, traditionally we have a tendency to tear between 11 and 3, but you can tear down to 9 p.m., and every once in a while you will see one that is 6 p.m., way down here. Quite rare, but it can happen. We've seen a couple of them, but they are pretty rare. Now, most commonly, I would say between 1 and 2 o'clock are traditionally where people are going to have their injuries, at least initially. And then if it starts to go towards the back, it becomes what we call a reverse Bankart. And you can have a full thickness, think of all 12 hours, what we call a panlabral tear. Now, the important thing to understand is that there are other muscles and ligaments that are responsible for stabilizing the shoulder. More so for moving, the labrum is in my opinion the main stabilizer of the shoulder, but there are other things that we need to move the shoulder. So you have the deltoids, anterior, middle, posterior deltoid. These are superficial. These are your deltoid muscles. Whereas you have your rotator cuff muscles and tendons underneath those holding, and that's what's responsible for actually lifting and moving. But the labrum and the surrounding cartilage is responsible for stability, because if there was no labrum, that ball would just slide right off that socket. It has to hold, that labrum has to hold that ball in the socket, so when you lift something up, it can handle it. Now, the rotator cuff tendons have a tendency to do the lifting, and there's 4 of them: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. Now, I will do that in a separate video because that is a separate monster and separate discussion. There's also the biceps, hence bi 2. The long head of the bicep is usually the one we associate with shoulder injuries. The short head goes into the chest and is the more important one, but rarely injured. You also have the pec minor and major, which is the chest muscles. The pec major actually attaches inside of the humerus, but makes up this kind of whole anterior towards the chest part of the shoulder. And then you have the rhomboids and serratus in the back, as well as the AC joint with all of the different ligaments on the top. So there's a lot of moving parts in the shoulder that are responsible and give it the ability to throw a ball, to catch a ball, to punch, to be able to hold on to a barbell above your head, to be able to grab something from the back seat of your of your car, to be able to put a bra on for a woman. All of these crazy maneuvers, to be able to scratch your back without dislocating your shoulder. All of these are required, and each of these muscles play a different role in that maneuver depending on what you're asking your shoulder to do. So when one of them is injured, it becomes much harder to do or more painful. Now think of the labrum as a suction cup, basically allowing hold the ball into the socket, allowing for that crazy range of motion that I just mentioned. And it's also a place where a lot of ligaments and tendons attach. There is what we call an O'Brien's sign. That's the technical term for what you'd use. There's a couple different tests. That's the most common one. And sometimes you can have pain and weakness. When I ask a patient, hey, do you have any concerns for labral injury, and sometimes I don't refer to it like that. I say, hey, does your shoulder feel loose? And they're like, yes, it feels loose. That tells me that they have a labral issue. If I ask the question and someone looks at me like I'm crazy, they usually don't have any labral issues, because if the labrum's beat up, they will be able to tell you, yes, it's loose. I can move it around in the socket. Sometimes when I grab for something that's heavier than I thought, it will even pop out, or we call sublocks. Then you can talk about how do you identify this. Well, exam does a great job. You can do something called a crank test, which basically means you lay the person down. You have the bad shoulder kind of just off the side of the table or bed, and then you start to crank on that shoulder. And if it starts to pop out, that tells you there's instability. And then you can kind of hold it and then try to reproduce it. And it's usually going to feel a lot better, because your arm is serving as the stabilizer for what should be their labrum, or the ligaments that are holding it together. If you want to get a visual, ultrasound is not going to be the best option. X-rays will do an okay job, but they're not going to show you any soft tissue. And in general, CT scans are really reserved for fractures. I prefer a non-contrast 3 Tesla MRI, and that's going to tell me the most sensitive information. I try to avoid contrast unless I'm super concerned, or it's a subpar quality magnet, usually a 1 or 1.5 Tesla. That I end up requiring a contrast. Most people think contrast is benign. It is not. I've seen patients 5 years later that have gadolinium in their body still from a contrast-induced IV that their body could not clear. So even though we say, oh, it's just for the sake of seeing that image, unfortunately, it is not benign. With the quality and the advent of higher level and higher, stronger magnets with 3 Tesla, namely, you can usually see these without any issues requiring contrast. So if you probably don't need to, and as long as the radiologist is good, you won't really have any concerns with not seeing it with contrast. Now, there are a couple different injuries that I mentioned earlier, and then there's a lot more complications that we'll talk about in a minute. Subluxations are kind of minor popping out, but not complete dislocations. So when you have a dislocation, it literally pops out of the socket, and the only way to pop it out is to tear that labrum that runs along the rim. And you can have what we call a TUBS, T-U-B-S, that stands for traumatic unilateral dislocation with a Bankart requiring surgery. Anybody having any shoulder dislocations or subluxations likely describe it as glenohumeral instability. That's probably the best way to describe it. And there is a genetic predisposition here that people with collagen disorders, because collagen makes up the main part of the ligaments and tendons for the labrum. Or you can have something called Ehlers-Danlos syndrome. And you can have a 270% increase in anterior shoulder instability and a 300%, 3x increase in recurrent instability if you have any of these genetic variants. Now, let's talk about the different grades of dislocations. Now, a grade 0 would be normal, no dislocation. A grade 1 would be slight translation on the glenoid rim, but not enough to pop it completely out of the socket. Now, that's what I would personally call a subluxation, which usually causes some problems, but not any major damage. When you get a grade 2, that's when you have that humeral head translation on the glenoid rim that will spontaneously reduce when the pressure or power is released or removed, and then it will pop back into place. Unfortunately, the grade 3s are also a dislocation with translation of that humeral head on the glenoid rim, but it does not spontaneously reduce, and those are the ones that have to be reduced physically. What is the risk of future dislocations? Well, this is fascinating. I'll tell you about the risk factors in a couple of minutes, but in general, it's 80 to 90% re-injury rate if a teenager, and over 90% if under 20 years old. As you start to get older, that percentage starts to drop. But if they're young, there is an almost 100% chance, very, very close, that it's going to happen again at some point in time. And every time it happens, you're going to injure more issues. You're going to have more cartilage damage. You're going to start to develop arthritis. You may have some big chunks of cartilage missing. You may start injuring the glenohumeral ligaments, which make it further worse. You may tear that labrum on the outside, and that's going to cause pain and instability and stiffness. There are several different types of labral tears. I'll kind of narrow them down to 3 generalizations. The first one is tearing it completely off the bone. As you can imagine, that's really bad. Then there is one it's more of a within the along the edge of the labrum. And then you have where the bicep tendon attaches, and we'll talk about that one first. We traditionally think of SLAP tears, if you've ever heard that term. It stands for superior labrum, anterior to posterior. Usually this is around 11 p.m. to 3 p.m. And usually it's kind of the whole top part of the shoulder. These are usually in overhead athletes, think baseball players, volleyball players, lacrosse, and there's a lot of instability at the top. You can have something called a Bankart tear. These are usually in younger patients who dislocate their shoulder, and they can feel like they can pop it out. And oftentimes you can have a bony Bankart versus a non-bony Bankart. A bony Bankart is a problem. That means you fractured off a piece of the bone along with that labrum. And when that happens, it's usually, by the nature of calling it a Bankart, it's usually on the anterior but inferior part. So you're thinking like 3, 4, 5, 6 o'clock, that range. Now, this is presented in 49% of patients with recurrent dislocations. So 50-50 shot, you're going to have a Bankart if you have recurrent dislocations. Now, there can be a defect in what we call critical bone loss. If that is over 10, 15, or 20, up to 25%, you're going to have serious issues and highly unstable. Now, if the glenoid rim turns into what we call a pear-shaped, the failure rate is astronomical, almost 90%. So these always require surgery. Sometimes they require grafting, taking it from your shin or from your pubic symphysis or your iliac crest, or there's different areas you can take it to make that rim bigger so that it can handle and prevent it from sliding off again. But this is a pretty advanced injury and definitely a big problem. Now, this happens in about 80 to 90% of those traumatic dislocations. It happens when you have a serious dislocation. It almost always injures the cartilage. The question is, did it fracture off the actual bone or not? You can have something called a Hill-Sachs lesion. A Hill-Sachs lesion is a chondral impact in the posterior superior, so you're thinking, 10, 11, 12, kind of this back part of the glenohumeral head. And this happens in 80 to 100% of traumatic dislocations. So pretty much think every time you dislocate your shoulder traumatically, this is going to cause that. Now, this is also in 25% of subluxations. So even the milder ones, about a quarter of the time, you can have an injury to this part of the bone. But the good news is that they are usually not clinically significant unless it engages the the glenoid, and then it becomes a problem. There's something called an HAGL, or a humeral avulsion of the glenohumeral ligament. Now, this is where we start to get into the weeds a little bit, but this occurs in patients that are usually slightly older. This can happen in females. Usually this is more of a male injury, but a high recurrence rate if not recognized or treated. And this one actually may require what we call an open procedure, meaning they actually make an incision as opposed to an arthroscopic procedure, given the severity and the location of that labral tear. And the glenohumeral ligament injury. Now, there's something called a GLAD, G-L-A-D, which is a glenoid labrum articular defect, and this basically means a sheared portion of the articular cartilage comes off with the labrum, and this is a risk factor for failure of an arthroscopic procedure. So this is usually a bad sign. And then finally, there is a variant called an ALPSA. So ALPSA. This is an anterior labrum parosteal sleeve avulsion. Now, this is basically causing the torn labrum to heal on the medial aspect of the medial glenoid rim. But it is associated with higher fail rates post-arthroscopic procedure. It is common with recurrent instability if you treat it non-operatively. So you dislocate it, do a little PT, baby it a little bit, dislocate it again. Every time they do that, this is going to cause more and more risk of ALPSAs. 97% of patients with recurrent instability have either a Bankart or an ALPSA. So unfortunately, you have recurrent instability, you're going to have additional issues every time you pop it out. Now, what are the risk factors for recurrent dislocations? The most important one is age. The younger, especially under 20, very, very high risk. Males, much more common than females. History of seizures. Traditionally, patients with seizures will collapse, not being able to break their fall, and usually the shoulder takes a massive beating. They try to do those non-surgically first, and then eventually, if they have to, surgically. If you're doing a contact type overhead sport, you're going to have a higher risk of dislocation. And then you can have hyperlaxity, like we mentioned earlier. Your shoulder is a little loose inherently. That already predisposes you to having a further dislocation. You can have a Hill-Sachs lesion on the anterior-posterior view and an extreme external rotation, and that will cause a risk factor, as well as loss of contour of that glenoid bone. If you start to lose the shape of it, you're at higher risk for dislocating. If these, and these are a scoring system, if you have more than 6 points, they recommend doing an open procedure. If it's under 6 points, you are still safe for a arthroscopic procedure. So the final section I'm going to talk about right now is really about treatment options. This is the stuff that I deal with every day. And do all labral tears require surgery? No. It really depends on the severity and the type. Is it 1 little hour? Is it 3 hours? Is it 6 hours? I have one in my posterior labrum that I can feel. I've never had it confirmed on MRI, but I know I can feel it. It doesn't bother me. I can still lift. I just leave it alone, and it doesn't do anything. I stabilize everything around it, and I've been okay. People with 3-4 hours, people that are trying to play sports, that have Bankart lesions, Hill-Sachs lesions, osteoarthritis is a fracture. You have a rotator cuff tear that's also there. Those are ones that have a tendency to end up undergoing surgery because there's so many things that are also injured. Now, you can also ask, what is the activity level of the patient? Is it on the milder side, or is this pretty advanced? If this is a patient that's relatively sedentary, it's probably not recommended to undergo a surgery that's going to take many months to get you back to 100%, or close to 100%. Whereas if you're a high-level athlete or someone who's participating and doing a lot of exercise or a lot of different sports, you're probably going to want to get it repaired if it's a moderate to bad tear, and I'll tell you about that in a sec. Especially if you're younger. The younger the patient, the more likely they are to dislocate, as we've mentioned. Those people have a tendency to want to get it repaired, but there are some issues with repair, and we'll talk about that in a minute. What other treatment options are there besides surgery? Well, you have anti-inflammatories, you have your stronger stuff if needed temporarily, like your narcotics and your tramadol. And then you have physical therapy, which can be very, very helpful for this, but sometimes not enough. Now, you can do a cortisone injection. While it won't particularly change anything, it will decrease some of the inflammation. It may calm down a bursitis or a little rotator cuff inflammation. It may help with the pain a little bit, but in general, it is not going to strengthen up that joint and is a temporary fix. And then you have your regenerative medicine injections, and this is what I specialize in. What we've come to realize over the past 10 to 15 years is that labral tears, whether in the shoulder, whether in the hip, do not just improve with PRP. What we've learned is that PRP taken from the blood, platelet-rich plasma, is not quite strong enough, regardless of how good your kit is, to address these injuries. It is important that you understand what PRP can and can't do, and what a stem cell or cell biological line is required. Now, in general, biologics or cell-based therapy are about 3 times stronger than PRP, and they have the potential to bring a lot more growth factors and cytokines, which in general significantly helps the labrum to be able to restabilize. And I've had fantastic results with labral tears in the shoulder and labral tears in the hip when using a stem cell line, whether it's taken out of your bone, whether it's taken out of your fat, whether it's using from a donor graft. You have many, many different variables, and you can mix and match them. Also, the important thing is making sure that needle is in the right spot. I personally take a very comprehensive approach when doing these with what we call a prolotherapy-based approach. So I basically walk along the labrum every hour. So I'll start right about here. You have to be careful. This is why a lot of people don't do this approach, because if you were to angle that too medially, you will be in the lung. You have to be very careful. But if you know what you're doing, you can walk that along the labrum, along that joint. And as long as you're not too inferior, you're not going to hit any blood vessels. You walk that up, and that's where most people have their issues. You walk it up here, you go up about a half an inch, go up there, you walk it in a little bit higher, walk it in there. Then you do straight down at the slap tears. You do a little bit higher for where it attaches actually. Then you go posteriorly. That's just for the labrum in the capsule. Then you have to hit the rest of the supporting structures. So this is not one single or 2 small injections and like, oh, my shoulder's fixed. If you try to take that approach, you are going to be disappointed, and you're going to dislocate it again. You need to hit the entire shoulder, usually 3 different rounds. The first one, the most important, the second kind of helping, and the third one is kind of the final reinforcement. This is a very frustrating injury, and some people, even after surgery, still have issues, and that's a lot of the times we see people with bad scar tissue or range of motion that they can't get back, or just there's other parts that they didn't repair that are now beat up. Remember, when someone's doing a repair, they're likely only repairing the part that's torn, but the rest of the joint is usually unstable and relatively weak. So they're not going to magically cut all of that and resuture it. They're usually going to hope physical therapy improves that. I don't like hoping. I inject every single part of the shoulder that is responsible for stability. Finally, let's talk about surgery. Now, there's several different types of surgery. It really depends on how bad the labral tear is and what other associated injuries. If there's a bony Bankart, if there's an issue to the glenoid rim, you might have to convert from an arthroscopic procedure to an open procedure, meaning they actually put an incision in and have to go in and actually address things. Now, in general, these do pretty well arthroscopically, but it is not a quick recovery. They're usually in a sling for the first month. Then they start physical therapy at about a month-ish, depending on the surgeon. And then at about 3 to sometimes 6 months, they're back to activity. I've seen people take up to a year to get comfortable again. The data is about 80% pre-injury level. So you never get back to 100% in terms of stability, strength, just overall comfort with a arthroscopic labral repair. The issue is if they put under 4 what we call anchors, then that increases risk of future injury. I've had patients that have had shoulder pain post-surgery. They over-tightened the capsule, so now they can no longer hit, say, a tennis ball from up here, or swing a tennis racket, or they can't get their golf swing high enough because the labrum is so tight onto that capsule. A lot of the times they have to go back in for a second surgery where they basically go in and cut and release the labrum that they just basically fixed, or some of the scar tissue that developed as a result of that surgery. That surgery is going to bring a lot of scar tissue. And that a lot of the times causes problems thereafter. You can have nerve injuries. You can have stiffness. You can have issues with the cartilage wearing down, what we call chondrolysis. And finally, you can have associated rotator cuff tears. And patients under 40 years old, about 30% of the times with that traumatic unilateral dislocation, you will have a rotator cuff tear, whereas it's 80% for patients under the age of 60. So that's a big range. Between 40 and 60, that range is almost guaranteed to have a labral tear along with a rotator cuff tear. And those ones become more problematic, and those ones cause a lot more pain. And if you start to get arthritis in the joint, which isn't super common, but it can happen, especially with dislocations, then those patients end up becoming more better candidates for shoulder replacements, either a total shoulder or reverse total. The rate limiting factor of those is a lot of those patients cannot lift more than 15 pounds overhead, because if you think of it as a ball and socket, or the opposite, a ball and socket, depending on if it's a total or a reverse total, and now you're risking putting weight up here to pop that ball out if you lift too heavy. So a lot of the stronger guys, they don't want to do that because they're worried about popping it back out again after the hardware has been put in. But in general, for the most part, surgeries do a pretty good job, but you can address these non-surgically. We've been doing it in our office for over 10 years and have fantastic results. And you usually don't have some of the same issues because the entire joint is being stabilized as opposed to one or two small sections. We have seen plenty of professional athletes, especially NFL players, suffer re-injuries and re-dislocations. Dalvin Cook comes to mind. And end up having to have surgery again because they retore the labrum after the first repair. So nothing is perfect, but especially in combat sports, any injuries like that, you're at higher risk for re-tearing. I hope you found this episode helpful. This was specifically about labral tears in the shoulder, whether by dislocation or just a chronic overuse. If you like this type of content, do me a favor, smash the like button, the thumbs up, and do me a favor and give me a review so that I can share this with more people. I have several other podcasts episodes that I recorded recently. We did hamstrings, we did meniscal tears, we did PRP, we did peptides, we did orthobiologics, we did ways to heal without surgery. We did something really cool called methylene blue. So there's all different things that I'm here to share with you. Eventually, we will talk about rotator cuff tears. So make sure you come back and check that one out. Thank you very much. We'll see you soon. Take care.